Okay.
The sound is fine now.
The sound is okay. Okay, so people, hola gente de YouTube, ¿nos estáis oyendo bien? Gente en Instagram, ¿nos oye bien? Ok. Para todos los que están en Instagram, ¿vale? Os animamos a pasaros, por favor, a YouTube, si podéis, porque tenemos la entrevista en directo con Paulo en YouTube y va a colaborar un compañero más, Diego Jaén, ¿vale? Así que si podéis pasaros, por favor, a YouTube, os lo agradeceríamos para que podáis seguir la entrevista de manera más fluida y mejor, ¿vale? En medida de lo posible, pasaros a Instagram, ¿vale? Los de YouTube nos están oyendo perfectamente. Okay, so it's 3 o'clock in the afternoon, so we are starting right here with my colleague Diego Jaén, that is co-presenting with me this audio podcast and this video podcast with Dr. Paulo Lucareli. Welcome, Paulo.
Hi.
Hi.
Hola, ¿cómo estás?
Bien, encerrado. We say closed at home. Okay, I want to present you Paulo. Dr. Paulo Lucareli is a physiotherapist, master science and PhD doctorate in health science in the Medical School of Sao Paulo. He is a professor and researcher at the science department in 9 de Julio University in Sao Paulo. And research director of the Brazilian Society of Clinical Gait and Movement Analysis. So he has a lot years of experience in clinical practice and research in neurological, but also in musculoskeletal disorder. And as we were talking yesterday in neurological disorder, we are going to focus today a little bit more of musculoskeletal disorder with Paulo. He has also his consultants, biomechanics consultant in ultra sport science, that is a center, a health center and coach center related with ultra sport sports, as running, cycling, and also swimming, isn't it?
Yeah, more in running.
In running, okay. So welcome to our podcast. Welcome, Diego, also. And we start with we are going to start asking you if you can tell us how did you start your career in biomechanics when you went out of the university, and how did you start with this field?
Okay. Good morning for everybody in Brazil and good afternoon in Spain. I'd like to thank you, Luis Henrique and Diego, for your invitation, and say to me it's really a pleasure to participate in this chat and podcast. It's really interesting, your idea and what are you doing, not just to talk with us, but to diffuse the field of biomechanics. I think it's really important. It's something that I love a lot, and it's a pleasure to stay with you in particular. As I told you, I'm not fluent in English. Your English is better by my Portuguese, but no. I will do my best to make you understand me, guys. So I worked for maybe 18 years in the field of movement analysis, of course in biomechanics. I started to study during the college, and after the college, I did 1 year of specialization in neurophysical therapy. I study gait analysis in neurological patients. In the early of my career, I did an internship at a good rehabilitation center that time, but now it's a huge hospital and rehabilitation center here in São Paulo. That has perhaps the most huge gait lab and maybe the most exams performed in Brazil, together with other gate lab in Brasilia, the capital of Brazil. At the ACD, I learned a lot of gait analysis, but only in neurological patients. And at this time, I did my master's degree and study stroke patients. After this time, I start my PhD, and as I'm not comfortable only to write reports, to prescribe surgery and orthopedic surgery, I did my PhD trying to understand the results of gait analysis and the effect of the gait analysis on gait training in patients with spinal cord injury. At that time, I was invited to set up movement analysis at Albert Einstein Hospital. That is the biggest private hospital in São Paulo, probably in Brazil, or maybe. And it was a really good time. And then I started musculoskeletal disorders studies, and in that time I start to be interested in understand how physical exam could be analyzed in the eyes of biomechanics, you know. I was not comfortable to only see the clinical results of a physical exam using a goniometer or using manual muscle testing. So I start to think, how can I put the physical exam inside the biomechanics instruments and see if it is possible to improve our quality of investigation, to take decision in terms of sorry.
Which are the first musculoskeletal disorders that you started to research or to study with?
At the same time, I was invited to start at the university, at the Nova Julio University. I'm a full professor at the postgraduate program in medical school and physical therapy school. But the most of the time, I'm a researcher. And when maybe 2 years after I started as an advisor, I had some students that asked me if I could mentor them in musculoskeletal disorders, and at that time I know some guys that convinced me to study patellofemoral pain. And during 10 years, I have been studying patellofemoral pain in probably all possible fields that my mind can think. Every year, I talk to my students that I don't know what study more in terms of patellofemoral pain. And every year, a new insight start, or a new student ask me about something that we don't have answer, and I continue to study.
And so if you are, as you say, you don't know how if you can study something more in patellofemoral. So which are the main biomechanical factors that you can relate with patellofemoral pain and patellofemoral problems in common people, but also in runners?
Yeah, I think biomechanic factors in patellofemoral pain was studied a lot in the past. We have a great scientists. We have a group of scientists that have a meeting every 2 years to talk only about patellofemoral pain. And they believe that some excessive movements like internal rotation of the femur related to the tibia and excessive adduction of the hip and hyperpronation of the rear foot. All of these things together with a pelvic drop and other secondary movements are related to the patellofemoral pain in terms of biomechanics. But I think it's more actual thinking patellofemoral pain as a multi-factor problems that is not related only with biomechanics, but we have psychosocial problems, we have anatomical problems, and other that probably we don't know. For example, neurological problems, not central nervous system problems, but in terms of muscles, for example, or synergy that I studied that we are conducting right now.
We've been yesterday talking with about muscle synergies with also with Sergio, but in cerebral palsy that he says that in cerebral palsy there's just two synergies, and in common people we use at least 4 synergies to work, and he was talking about a little bit about that. So you also say that probably there's a muscle synergy fault or error or mistaking also in patellofemoral pain?
Yeah, this is a really good coincidence because the last time that I talked with Sergio in Seville, I think in that conference was the time that researchers are talk more about muscle synergy. The synergy are pop star in the conference, and I used to go to this conference, especially in this conference, European Society of Movement Analysis, to see what people are doing more in neurological patients, but to take some advantage and try to use what they are doing and try to apply this in orthopedic patients. And that's what I visualized in that time. I saw Michael Schwartz, that is a really good researcher and engineer in St. Paul, Minnesota. And he showed us that the muscle synergy in that time was better than kinetics and EMG together to indicate surgery. And I thought maybe our patients in orthopedics should have something different in terms of muscle, because it's not possible that if the biomechanical problem is the movement, and I exclude in this comment other possibilities or other factors like psychological and others, the machine that move the bones are muscles. So in some parts of this, not only strength, could be a problem. And we start to try to understand this. My ex PhD student Cynthia studied this synergy together with colleagues from Madrid, from Ramon and Cajal Institute, because the calculation of the muscle synergy is not so simple.
Yeah, I know.
It's not so simple to calculate this, and it's really important to us to learn with other centers. And we applied this, and we just submitted the first paper. I hope will be approved and accepted. But what we saw is that during the lateral step down, have some difference in terms of muscle synergy, not in terms of number of synergy that is common in neurological patients. Neurological patients, we see less muscle synergy than in a typical patients. But we saw that the number is the same or almost the same. But in the structure of the muscle synergy, part of the patients have less coordination in muscle. So another problem, part of the patients could be one problem and part of the patient could be other problem. And it's related. What another interesting thing that we saw is that it's really related to the quality of the movement. So better quality of movement are related with the less coordination in terms of muscle synergy, you know.
Yeah. Really amazing. Diego, any question on that side?
Yeah. So as I told you before, Paulo, I would like you to explain how would you transfer all the knowledge that you have acquired through research, okay, to the clinical setting, okay? Because I'm sure that most of our audience is very interested in that.
Yeah. I think it's a good point to discuss, and maybe this is not a particular problem here in Brazil, but around the world, maybe. I will talk about Brazil and maybe more specific in São Paulo. We have a few professionals qualified to use biomechanics clinically. We have great professionals. Most of them are theoretical. Most of them are part clinical or believe that they are clinic. But many people know biomechanics, but they have done masters and PhD in biomechanics or in related area. However, they are not able to interpret data and make decisions to treat patients. That's what I have seen in the past and in the present, and I really like to change this in the future. But just to give you an example, sometimes here in Brazil, I teach gate course, and when I start to show kinematic graphics, people sleep, go outside the room, and I have to use the audience like when you show video. But we have problems with this. So I don't know if it's a problem related to our background in terms of college in healthy university that don't teach mechanics We teach bio something, but not mechanics.
Yeah.
I have teach biomechanics. When you start to talk about a vector, buggy, the brain buggy stop,
Yeah.
you know. And it's more difficult, in my opinion, to see the graph, not how to manipulate the instrument that we are talking earlier. It's not to put markers in patients or IMU or EMG, or say to patient jump or walk in force plate and record the signal or process the data or use a filter or whatever. It's when you print your graphics, look at them and you see your patients. Are you seeing your patients in these graphics? If the answer is yes, we have another problem. What to do now as a physio? What to do now as an orthopedic surgery? What do you do now as a, I don't know, pediatric? I'd love to see this in the future. I don't know if I will be alive to see this, but I'm looking for this. It's a dream. It's a dream for me. Really.
Here we have the same problem. You know, I teach in the first year of physiotherapy degree in biomechanics. We have the subject divided on 3 stages. So one is the physical part, where we teach vectors, what is the speed, how to calculate, and all that. So when we start with this part, they are they have fear. They think that they are going to fail, that this is bullshit, and they don't know, they don't need this to understand what is happening to a patient. So then we have the second part, that is how is the biomechanic, the musculoskeletal biomechanics, so how a muscle contracts, and how is the joint biomechanics of a knee or a shoulder. And then we have applied biomechanics, that is the part when they see how we make a gait analysis with a camera, with a 3D, with a with a plantar pressure and all that. They love this part, so how to do it. But when they arrive to the graphs, so they say, okay, so that's happy and that's funny up to this point, because when they have the graph, and we do a lot of graph interpretation practice and teaching, and I have videos of how to interpret that, but they don't want to. And I say, if you present me graphs of a patient without seeing the patient, without seeing a video, I have a lot of info, and I can even imagine what's happening on this patient. But up to this point, you should train a lot. So I think there are 3 steps. So one is the technical part, how to do it. The second part is how to interpret this, that is the assessment. And the last is what to do. That is the third part in decision making. And I think, as you have said, that in the first point we have several professionals that can do it technically, but in the decision, even some of them can get good graphs and do it quite good, but interpreting that and do a decision making in physiotherapy or in other specialties, there's not so many people able to do that at high level, I think.
Yeah, I agree. In terms of this issue, I think the neurological area or pediatric orthopedic area are a little bit more forward than the musculoskeletal area, as they are discuss how to interpret the data using artificial intelligence or whatever. They are in I think some steps in front of us, but it's not easy for example, doctors, physicians, or physio that work with clinical scale, that I think it's important. I don't think biomechanics is the only thing that is important in terms of evaluation. I think it's have the same weight as a X-ray or MRI or physical examination. We have to put all together. But the history showed us that when you use this information, we improve the knowledge of the movement. So if we improve the knowledge of the movement, for me, it's not possible that we don't move forward in terms of the treatment.
Yeah.
Or not improve, or say that something are wrong and go back and think again and go forward again, you know?
I call this always biomechanics, you know, so instead of biomechanics. So what we should do, and we should integrate biomechanics with the rest of the info. And in that direction, I want to make you the next question for you. That is how you integrate your knowledge in biomechanics with the rest of your team. So medical doctor, coach, other physiotherapists, and other researchers or other fields like engineers or something. So how you collaborate in this field? So are you part of the decision making, or you are just like an external lab when you just create a report and they interpret it, or how you connect all that stuff?
I leave it, or I realize in almost 20 years, different scenarios. When I worked in a rehabilitation clinic center, the team are composed by physio, surgeons, engineering, and every week we sit together and discuss all patients, and it's really, really, really nice. It probably was the period of my life that I improved my knowledge more than in others. Of course, I improved my knowledge at the university, because some students ask very difficult questions that I don't know how to answer. I have to go to home, study, and then next day try to answer. But when you think in putting different persons that study different areas, our way to think and take decisions change a lot. Sometimes I will take some decision and I have the opportunity now to stay with an engineering that worked with me at the ACD, at Albert Einstein, and now it's in a clinic and in our lab, and I talk something that I think in terms, for example, run, and he said, no, take a look on this. The vector, the movement, the moment, the arm moment is this, and probably the movement, it's not like you are thinking. But I don't know, there are some muscles that could do this. And I say, yes, the muscle is that. So write this, because you are create an external or internal moment that will probably improve the movement. So are different areas put their knowledge to improve patient.
Yeah.
I think it's really, really, really interesting. I'm very happy to work with people like this. and I don't have any problem to say that I don't know, or to say that I don't know how to do more for this patient. Could you help me and answer uh, other experts? But sometimes I have not these days, but in the past, I had problem to discuss with some physicians, especially because we give the report and the physician said, no, I do for 50 years in this way. Why are you change now? Just because you have 12 cameras and you have force plates? No, I do this, and I'm not changed. But now that we have new guys in the area, I think we have more possibilities. People that are more open to listeners as a biomechanic.
Yeah. Paulo, getting back to your research, okay, and to the topic of the patellofemoral pain, okay. I know that you have been working with women, okay, and could you explain how different these mechanisms is or are between men and women? You explore that?
No, but I would, or I could. I don't know exactly. I have been studying more or only women until now because the prevalence is higher in women than in men, and in here in Brazil are more physiotherapists women than men, so it's easy to recruit subjects to my studies.
Okay, yeah.
But there are some, not too much, but there are some researchers that compare women and men. If I'm not wrong, during running, but they put all together, if I'm not wrong. And there are a good paper that is from Brazil. It's from Fábio Serrão from São Carlos State University, and they compare strength and some kinematic variables. Men tend to be less range of motion related to patellofemoral pain, you know. But I have to answer the reviewers every time that I submit a paper. Why I'm study only women? It's because it's 2 times more women that have patellofemoral pain than men. So it's easy, but I think it's necessary to understand what happened with men.
Okay.
I don't know exactly.
Yeah. Do you think that this patellofemoral pain is related to the menstrual cycle?
Good question.
Yeah, thank you.
It's a good question, but to be honest, I never.
Maybe it's not related to any of the phases of the menstrual cycle, or maybe not. I don't know.
Yeah, I don't know if, for example, if the menstrual cycle during that time the pain improve or decrease, or if the biomechanics it's different during this time. Probably yes, because the menstrual cycle change everything in a woman more in one part than the other. But to be honest, I never seen anything related to this. But as in sports, probably yes.
The
The answer probably.
Diego is asking you this because we are starting a project with women and how they run, but taking in account the menstrual cycle and if there's any to see the difference in motion and other parameters during different weeks of the menstrual cycle. This is why he is asking.
In women with pain?
No. In health women.
Okay. My hypothesis is that we will have difference in some way. I don't know, in psychological scale if you use, or to be honest, I don't know if you have difference in kinematics, for example, or kinetics. But when I'm interviewing women and they are during the menstrual cycle, during this time, it's a little bit different than the talk, you know, the chat, it's different. It's more sensible, it's more, and it's really related to the pain. I'm not the best person to talk about pain, but pain in terms of a neurophysiology. But my opinion is that some difference could be seen.
Okay, we will take it in account. We are just now starting with the methodology, and we are doing some trials and try to structure how is the research. But it's a starting idea, and we are now just starting with that. Okay, so I want to move a little bit in the interview because we, as for example, you know that you are using Bicon or and force plates and EMG and all that, but this, as you say, in Sao Paulo, maybe there are 10 labs like this, but the common physiotherapists and the common podiatrists and sports scientists, they don't have access to $100,000 lab. So and that's always a key point for people to start on biomechanics. This is why I think that's a problem to start and to spread the word on biomechanics. And I started 10 years ago with a camera and a plantar pressure plate, and then I start with I open the field with more and more sensors. So what's your opinion, your idea, or what's your starting kit on biomechanics? So if you imagine that you are a common physiotherapist or a common podiatrist, or here in Spain, I should say that podiatry is also a degree at university, so it's 4 years at the same level as physiotherapy, but not in all countries are like this. Or if you are a sports scientist and you are interested on biomechanics, what is your starting kit? So to start to do something on biomechanics.
Okay, easy question.
Easy?
No, it's not. It's not. So I think it depends what we are interested in analyze. It depends. So I think the first instrument that we have, it's our eyes, but the experience of our eyes depends of the results of who we are seeing. Sometimes people here in Brazil asking me about 2D analysis. Some software is free or low-cost software using 2D analysis. Sometimes I answer that depends of the problem of the patients. I prefer to use my eyes.
Yeah.
If the person don't have the expertise to use 2 or 3D, don't use it, because if you, I will do an example. I will do an example here. If we have a car, I don't know, thinking the worst car that you guys have in Spanish,
Yeah.
and I will give you as a gift a Ferrari.
Yeah.
So you have the best and the worst as a car.
Yeah.
And I ask you to go from Zaragoza to
Madrid.
Barcelona.
Yeah.
Or Madrid.
Yeah.
You can go to Madrid using the worst and the best. But if you don't know how to drive a Ferrari,
Yeah.
you can't.
Yeah.
And if you don't know that the worst car in Spanish have to be driving with carefully because something can be broken or something, you can't go to Madrid. So if you have one camera, it's possible to do biomechanics. Yes, it is. If you have $1 billion, you can do markless motion capture that Qualis are doing now. But for me, the problem is it's not only the instrument. The instrument is not the principal part of this. It's the most important part is what we talked some minutes ago. It's people know how to use it. People know the concepts, because if you don't know the concepts, I don't see any difference using a video camera with 30 hertz or super high camera with 10,000 hertz. I don't know.
Yeah.
Doesn't matter. If you to click in a button, a monkey can do this.
I started with video, and when I started doing some video analysis, and I tried to look how to do it, so I didn't find anything, So I didn't find anything. So I looked for how to do a video analysis, and you don't have you don't have books, tutorials, or nothing to understand. So I write a paper a few years ago, but it was in Spanish, about how to start, just how to put the camera, how to select a correct hertz, or how to illuminate, where to put the markers, and how all that stuff improve the motion analysis. I published last week a comparison between a 3D motion analysis with Vicon of knee flexion extension and with a camera analysis, a good camera analysis, and you have almost the same graph. So you have less than 2 degrees of error with motion. But when I see the videos of people that they are registering in oblique, with the camera in inclination, without any marker put or anything, so you are measuring shit, because you cannot say anything with that. So I say you can use a camera, but you can use it if you do it in a proper way, and that means time, usually time, knowledge, and a lot of training, as you say. Expertise in analysis, you say that word exactly. So expertise, and do it once and one time, another, and correct. And with all that in mind, you can do with a camera. But if not, as you say, you can use your eyes if you have good eyes, not mine. But if you have good eyes, you could have better assessment than in a 2000 video if you register bad, or if you don't know where to see it or where to look for the information.
Yeah, I agree with you. The problem is, well, first of all, congrats for your paper. And I think it's okay to use in some joints, for example, like you said, knee flexion extension during gait or running. The problem is that people that don't understand or don't study biomechanics, you read your paper and you use it to analyze fingers.
Yeah, I know. But I start with the main problem of 2D, that is the parallax, the parallax. So I start always with this.
Yeah.
So this is 90 degrees. This is 90 degrees, but this is also 90 degrees, even you cannot see it, or this is 90 degrees, even if you don't. So, and the scissor is always in 90 degrees. So, for example, knee flexion extension or hip flexion extension or something like that. So if you put the camera or you measure, you can have a very good measure. But as you say, so that's the first key point, and I start always with that. So when you are seeing a video, you are doing always an error, but you can minimize this error by making all that stuff in this motion. But for example, you cannot assess knee valgus, for example, or knee varus, so you cannot differentiate that with internal hip or external hip rotation. So you cannot measure anything in a frontal video, for example, So I completely agree with you.
Yeah.
Okay.
Yeah, we have. I agree. Just one comment, a small comment. People have to think and have in mind that, as you said, all measure instruments have error.
Yeah.
You have to understand how your instruments have error. For example, you use Vicon, I use Vicon, or if we use another company, I don't know, Qualis, Motion Analysis, I don't know. Use your calibration wand, and you know the distance between the markers or the LEDs, and move your calibration wand to the corner of the room and in the center of the room, and measure if the difference is the same between the markers or the LED, depends of your calibration wand you have. It's different because independent if you have 2D or 3D, we have an error in the measurement. And more, we have measure in the instrument, and we have a lot of problems in the biomechanic models. Sometimes we use until now a model that was built or was published in 17s, 18s.
Yeah.
We didn't improve it a lot. No, I use clusters or cast or plug-in gate or whatever, Dave's on Tiburski, I don't know. I don't know any paper that say that one is better than other.
Agree with you.
Problems.
Diego, we are moving. We have been talking for 50 minutes, so even it's very fast. It's also almost an hour. So I don't know if Diego, you have any question for any more question for Paulo.
I don't have any more questions, Paulo, but I have something to propose to you. Okay, so as little.
Wait, Diego.
This menstrual cycle influences on them, okay, on females, and we would like to count you in if you like, just if you want to to act as a consultant, okay? Because you said that you are a biomechanics consultant, and it would be great to count you in, and I'm also particularly interested in EMG, okay, and I know that you have been working on with EMG as well, and then yeah, we maybe in any other moment we could talk about that also. Yeah, so
sure.
Yeah.
Would be a pleasure. But as I say to my student, EMG it's not from God.
Yeah, I know. Yeah.
And to be honest, I don't know how exactly EMG during running. It's easy to perform.
Yeah,
but
yeah.
we can test and see variability or whatever. I have a good professor that know a lot about EMG, helped me in all studies that have EMG. And when I try to ask you about running an EMG and he go off the room. No. Impossible.
Yeah.
A lot of
I use a fine wire. No, no.
A lot of.
I found that answer as well.
Yeah, but what surprised me is that there are papers that use EMG during running or fast movements. So maybe we can learn with them. There are interesting paper. I don't know if you read yet that calculate the muscle synergy during running.
Mm-hmm.
Have you seen this?
No.
No.
We will look it for.
I can send you. Of course, we can talk. I have been talking with Luis Henrique for a long time. We are trying to do something. COVID, it's stop or pause our thinkings, but of course we collaborate with each other in the near future.
Okay, so to finish, thank you. I want to thank you, Diego, to stay here and help us with the interview. And Paulo, I want to thank you a lot to stay this hour with us and try to show us a little bit of your experience with motion analysis and all your experience in research and clinics. So thank you very much, and I hope that in few months of maybe a year we can try to make a trip from us to Brazil, or maybe to take you here to teach us something in Spain. So we will see if in Portugal or in English with translations. It doesn't matter. So we will find the way to do it. So thank you very much, Paulo. I hope you enjoyed this hour with us, and please feel free to say if you have been happy with that and all that. So.
Of course, no, I'm really glad to stay with you guys. To be honest, I don't sleep well last night thinking this interview.
No, I don't believe you. I don't believe you.
Really, believe me. But now I'm really relaxed.
Why?
You're relieved.
What do you think that
because I really don't do this in Portuguese. Thinking to do this in English, it's not easy.
No,
and but I enjoy it a lot. I enjoy to meet you in person and in Diego. To me, it was a pleasure to talk, and I'm more happy than I could stay because I understand that we think we think in the same direction, not equally, of course, but we think the same in terms of biomechanics, in terms of the problems, in terms of whatever. And I hope to talk with you guys as soon as possible.
Okay, so thank you very much for spread the word of biomechanics with us. And just stay a minute. I close the program and I stay with you 2-3 minutes more. Okay, so just wait a minute. So thank you, friends, for staying with us on live, on Instagram Live and YouTube during this hour. I hope you enjoy the interview with Paulo and Diego. Please stay tomorrow with Mark, that we have from Kenya, that he works with his physiotherapist and he works with the best Kenyan distance runners. So I hope you enjoy also the interview tomorrow. So thank you very much for all, and we see you tomorrow.
See you guys.
Wait a minute.
Bye-bye.
Bye.
Paulo, wait.